Okay, good morning, everyone. I'm going to call the House Human Services Finance and Policy Committee to order. I'm also going to note that the rules for the committee have been distributed to members of the committee. So please take a look at the rules. We do have a 24-hour rule just because of this remote environment to help the staff give them time to get amendments ready. So the first order of business is we're going to take attendance. So Ms. Hanson, if you could call the roll and please unmute yourself.
Sure. Good morning, everyone. I have to hold our dog because the UPS guy is coming and she will start barking. So Chair Schultz.
Present.
Vice Chair Bonner.
Present.
Representative Albright.
Present.
Representative Bolden.
Present.
Representative Burkle.
Present.
Representative Fisher.
Present.
Representative Frederick.
Present.
Representative Hanson. Not yet. Representative Keel. I see you.
Present.
Representative Liebling.
Present.
Representative Moeller.
Present.
Representative Noor.
Present.
Representative Novotny.
Present.
Representative Pearson.
Present.
Representative Pinto.
Present.
Representative Rasmussen.
Present.
Representative Robbins. Representative Sandell.
Present.
And Representative Schumacher.
Schumacher, present.
Thank you so much.
Thank you, Ms. Hanson. You have a very cute dog.
Thank you. She's trouble.
So we have a quorum present. We've been very good about most members attending, so thank you for that. We need to make a motion. Do I hear a motion to approve the minutes from January 21st, 2021?
So I'll make that motion.
Okay, I heard Representative Albright moves the minutes from January 21st. Any discussion of those minutes or corrections? Okay, hearing none, please unmute yourself for a voice vote. All those in favor say aye. Aye. Any opposed? Okay, the minutes are approved. Thank you. So today, members, we have two presentations. The first one is going to be an update of assisted living licensure. So this licensure bill was passed in May of 2019 with strong bipartisan support. And I want to commend all of the work that went into passing that legislation, especially to our stakeholders and advocates. They worked hundreds of hours to get to a compromise to gain that bipartisan support. So we're giving an update on the licensure and the rulemaking that's currently happening. And then the second presentation is about our skilled nursing facilities. So we're going to learn about the rate structure, the value-based reimbursement, and hopefully we'll have plenty of time for questions. So I'll ask for questions at the end of each presentation. So just please use the raise hand function and we'll start a list of members. Okay, so the first presentation is, let's see, we have Assistant Commissioner Diane Rydrick and Director of Office of Health Facilities, Lindsay Kruger here. They're both from MDH. So I think Assistant Commissioner Rydrick, are you going to be presenting first?
Madam Chair, I'm just going to give a brief introduction and then I'll be turning it over to Ms. Kruger.
Okay, thank you. Welcome to the committee. Please proceed.
Thank you. And hopefully I can balance both my phone and my laptop here. No dog on the lap though. So yet. So Madam Chair and members of the committee, for the record, my name is Diane Rydrick and I'm the Acting Assistant Commissioner of the Health Systems Bureau at the Department of Health. Thank you for having us here today to talk about assisted living licensure, and thank you for moving the date from last week. As you'll hear, last week was involved a 2-day long public hearing on the proposed rules for assisted living licensure, and so that obviously was a lot, and so we appreciate the extra time to prepare for this conversation today. I'm going to make just a couple of quick points and then I'll turn it over to Lindsay. We know that there are several people here who are new to your committee and potentially to this issue. So we are going to provide some deeper background on the population served by assisted living facilities and the previous regulatory environment prior to the passage of the assisted living licensure statute before we get to updates on current activities, but we'll move pretty quickly through all of it. It's important to understand that getting to where we are right now has involved, as you noted, Madam Chair, multiple years of effort by countless numbers of stakeholders. The assisted living licensure effort grew out of a sense of shared frustration with a system that was confusing for families, residents, caregivers, and for the industry itself. It lacked transparency and consistency in terms of protections for residents, and it made it really difficult to establish clear pathways for accountability for MDH. And the system that we have now that we're about to unroll is certainly more straightforward, more consistent, more transparent in terms of expectations for residents and families and for the industry that is participating in this. And before I turn it over, I just want to note, as this group knows so well, COVID has taken a serious toll on residents of long-term care facilities and on their families, as well as on the staff who work in those facilities every day to take care of residents. It has also taken a toll on MDH, and it has impacted us and our work in different ways. Some of the timelines for this work got pushed back farther than we would have wanted because of the number of staff that have been redeployed to work on COVID response. But throughout this last year, we have maintained our commitment to this work and to ensuring that we have a strong system for protecting assisted living residents. And it's a critical priority for us at MDH. So we are now, despite the events of the last year, on the cusp of finalizing the rule and moving to implementation of the new system later this year on schedule. It has been a little bumpy at points. There will probably be other bumps in the road before we get to the summer and to launching this. But these are really significant milestones, and we're at a good place right now in terms of the progress we've been able to make and in terms of really maintaining that consensus among a really varied group of stakeholders. And we feel proud of that progress. So we're very fortunate to have strong leaders leading this effort within the Health Regulation Division, and I'm going to turn it over to one of them, Lindsay Kruger, who heads our Health Facilities section and is the point person for this effort. She has been balancing moving this forward at a quick pace while balancing those different needs and perspectives and really keeping the safety of residents as our North Star throughout the process. So without any further ado, I will turn it over to Lindsay.
Thank you, Diane. Good morning, Madam Chair, members of the committee. For the record, my name is Lindsay Krieger, and as mentioned, I'm a program manager in the Health Regulation Division at the Department of Health. I have been assisting with the planning and implementation of assisted living licensure, and I look forward to taking you through the overview of the assisted living licensure and implementation updates. Next slide, please. Now, to give an overview on background and numbers of assisted living type settings, there are approximately 60,000 people living in 1,663 assisted living settings across Minnesota at this time. Now, in 2014, about 58% of the residents in assisted living were over the age of 85 and 39% had dementia. These residents are aging in place and living in these settings longer, which means that care needs to be provided at a higher level. Next slide. If we look at data in the 1980s, on the left-hand side of on the slide on your screen, you can see the data relating to nursing homes. There were around 468 nursing homes and roughly 48,300 beds. Now, today in Minnesota, we have 364 nursing homes and approximately 23,000 residents living in this setting. And if you take a look on the right-hand side for the data for assisted living establishments, in the 1980s, there were none here in Minnesota. Today, we have approximately 2,480 housing with services and 1,663 home care providers, which provide care to approximately 60,000 clients. Now, this is over double the residents in nursing homes. And I will further on talk about housing with services and home care providers and how together they make up what we know as assisted living type facilities today. So next slide, please. So there are three main statutes, but what we know or most people know as assisted living type facilities today. At the top, you will see 144D, which is housing with services. Housing with Services in 144D is a registration. Currently, if somebody is interested in becoming a Housing with Services, which is a building that provides sleeping accommodations to one or more adults, at least 80% being 55 or older, and offers supportive services such as laundry or transportation, or health-related services such as central storage of medications, they would register themselves with MDH as Housing with Services and pay a $155 fee. Now in the green circle is 144A, which is home care. A home care provider is a provider who is regularly engaged with at least one home care service, such as assistive tasks for unlicensed personnel, activities of daily living for clients, services by a registered nurse, and medication management, just to name a few of the services that home care providers do provide and offer. And these home care services are provided in the client's home. This could be a home in the community or their apartment or room within the Housing with Services setting that I just mentioned. And then finally, the final circle in the reddish color is 144G, which is known as assisted living. Now, the term assisted living is currently a designation. This is a designation of someone that has a Housing with Services would denote on their registration. To be an assisted living, you would need to meet the minimum requirements in 144G, and you could only advertise as an assisted living if you had this designation. So these three main statutes today make up what we know as assisted living type facilities. Next slide, please. So to further break it down, 144D and 144G as part of that three-circle ring have an annual registration, but no statutes for inspection, no mandatory incident reporting, no complaint investigations or physical plant requirements, and clients do have or are protected by the landlord-tenant law. Now for 144A, there is an annual license, and there are surveys on the temporary licenses that are issued and inspections every 3 years. The providers are required to report incidents per the Vulnerable Adults Act, and the Department of Health does have complaint investigation authority. Clients are protected by the Home Care Statute in 144A, the Vulnerable Adults Act, and for those under 18, child maltreatment. Next slide, please. So let's take, for instance, the Blue Roof Inn. The Blue Roof Inn provides the sleeping accommodations for the client, including the roof over their head and the structure of the building they live in. The Blue Roof Inn partners with Green Acres Home Care to provide home care services to clients who live in their building. Now, as a reminder, these services could be assistance with activities of daily living from an unlicensed personnel, services from a registered nurse, or assistance with medications. Now, these two providers, the Blue Roof Inn and Green Acres Home Care, are providing the building and the services for the client. In some establishments, they are the same entity or person who owns and registers the building and holds the home care license. But in other situations, one entity or person owns and registers the building, and a different entity or person owns and licenses the home care. Next slide, please. So this brings up the challenges as to potentially who's responsible for something that is in the license or in the contract for the home care services, or is it something that's involved with the building? Now, as a reminder, there is not a license for the Housing with Services, and the assisted living is a designation. So if there are concerns about the building, the state of the structure, let's say, these concerns would need to go to local jurisdictions, as the Department of Health does not have authority over the building itself, as the Housing with Services is a registration. Now, there are numerous instances of people who are involuntarily discharged from services and or evicted from their units or apartments. And this lack of transparency about what services a client gets for what fees and rates that they provide and pay for, and how that works, there can be surprises with huge bills that people do not expect. Next slide, please. So where we've been, let's take a look back in 2018. So in the 2018 legislative session, there was proposed legislation, but the final bill was not signed. Also in 2018, the Office of Legislative Auditor came out with a report on the Office of Health Facility Complaints, identifying areas of concern not only within MDH, but also in statute. The auditor recommended that the Department of Health establish a work group to examine the state's oversight of senior care providers and housing facilities. So in the fall of 2018, Commissioner Malcolm convened 6 working groups, as listed on the slide, that took a look at a variety of topics, including licensing approaches, certification for dementia care, and consumer rights. Next slide, please. Moving along to 2019, in May of 2019, as mentioned in the opening, there was tremendous stakeholder support and work that went into assisted living licensure and the drafting of assisted living licensure, and that licensure was passed in May. So what the assisted living licensure does is combines the housing portion with services under one license. This removes the housing with services registration. Assisted living licensure does have the effective date of August 1st of 2021. Now within 144G, in 144G.09 subdivision 3, rulemaking was authorized for MDH to adopt rules for assisted living facilities that promote person-centered planning and service delivery and optimal quality of life, and to ensure that residents' rights are protected, resident choice is allowed, and public health and safety is ensured. Next slide, please. So in the fall of 2019, MDH started drafting the rules as directed in 144G. Now, a rules advisory committee was also set up that included stakeholders who participated in drafting of 144G. And there were meetings held from November until March when the pandemic hit. The MDH rules team did keep in contact with the advisory committee and held a final meeting with them in November of 2020 to walk through the proposed rules. The notice of hearing on our rulemaking process was published last month in December, which opened the 30-day public comment period leading up to the hearing. And I will be discussing updates on the rulemaking process just a little bit later on in this presentation. So let's talk a little bit about the key highlights of assisted living licensure. So assisted living licensure, as I mentioned, does bring together a single license and assisted living contract. The residents in assisted living will now have one contract for the housing portion, and also that same contract will include their services. There is also added physical plant requirements and fire safety. There's also enhanced Bill of Rights and consumer protections and the licensing of assisted living directors. There is further clarity on facility responsibilities and requirements, and there is some improvement and structuring of surveys, investigations, and enforcement. Next slide, please. So there are 2 categories for the licensure. One is assisted living license, and one is assisted living license with dementia care. The assisted living license provides housing and services to the residents. They may also provide assisted living services to residents with dementia, but they cannot advertise as providing specialized dementia services. Because a resident has dementia does not mean that they can't live in the assisted living setting. A resident's diagnosis does not dictate where they live. A licensee must meet the resident's assessed needs, and an assisted living license is prohibited from having a secure dementia care unit. Now, the second type of licensure is assisted living license with dementia care. Now, this is the same as the assisted living license with a few extra pieces in place. These providers can advertise as a facility who specializes in care for residents with dementia. They also need to meet some additional requirements of the license, training, and programming. For the license, the applicant needs to demonstrate capacity to provide services to residents with dementia. There is an additional dementia-related training that is required for staff, and there's also increased programming, spontaneous activities for enjoyment or diffusing of behavior, one-to-one activities that encourage positive relationships between residents and staff. And this facility type, or this license type, may have a secured dementia care unit. Now, some of the requirements in the dementia care unit is that they do have to have an awake person physically present on the unit at all times. There are also more stringent requirements for fire safety, and they do have to have an automatic sprinkler system throughout the facility by August of 2029. Next slide, please. So physical environment highlights, starting on August 1st with the implementation of assisted living licensure, there will be a physical environment survey every 2 years. MDH Engineering will be conducting plan reviews and inspections on any new licenses or new construction through the Department of Health. There will need to be smoke detectors in each occupied room, or the building needs to have an automatic sprinkler system. There's requirements for portable fire extinguishers, and fire drills are also now in statute. And the physical environment needs to be in good repair and maintained in a manner that does not constitute a distinct hazard of life for the residents. For minimum requirements for staffing, includes a biannual evaluation of staffing levels. And staff must be in place to meet the scheduled and reasonably foreseeable unscheduled needs of each resident at all times. There's also minimum requirements for food now. The assisted living provider needs to offer to provide or make available 3 nutritious daily meals 7 days a week in accordance with the USDA guidelines, and food must be prepared and served according to the Minnesota Food Code. With the passing of assisted living licensure also came enhanced Bill of Rights. This includes the right to care from staff who are properly trained and competent in sufficient numbers. There's also the right to have a legal or designated representative participate in care and service planning. In statute, there's resident and family councils, and access to technology, and immediate access to counsel and advocacy services. Now, as mentioned, there is now going to be a licensed assisted living director, LALD. The Board of Executives for Long-Term Services and Supports, also known as BELTS for an acronym, which was formerly the Board of Nursing Home Administrators, is going to follow through with licensing the assisted living directors. The BELTS board will approve the director qualifications and training, and they are currently in the rulemaking process at this time. Now, they do anticipate online application rollout no later than May 1st of this year. And per definition, the licensed assisted living director, as defined, is a person who administers, manages, supervises, or in general administrative charge of an assisted living facility. Now, highlights on surveys and enforcement. The assisted living facilities will be surveyed every 2 years, and the provisional licenses surveyed within 1 year. Now, a provisional license means if they send in their application is complete, and MDH issues a license. It is a provisional license at that time until they go through the full survey process and be granted a full license. Now, there are increases in fines for enforcement with the passing of assisted living licensure, and this actually went into effect last year. These fines include $500 for level 2 fines, which is a violation that did not harm the client's health or safety, but had the potential to. $3,000 for level 3 fines, which is a violation that harmed the client's health or safety, not including serious injury. And then $5,000 for level 4 fines for a violation that resulted in serious harm, impairment, or death of a client. Now, also set up is a maltreatment compensation fund. This is in place for a home care provider who is found responsible for maltreatment, and a fine of $1,000 or $5,000 depending on the severity of the allegation and the finding. And these funds can be collected by the client or the client's representative if they accept payment in full and agree to waive any civil claims. Now, regarding implementation updates, there are 4 key activities that we are currently working on, and I'm going to turn it over to Mark Schultz, our legal policy specialist in the Health Regulation Division, to discuss legislation.
Good morning.
Welcome, Mark Schultz. Go ahead and proceed.
Good morning, Madam Chair and members. My name is Mark Schultz, for the record, legislative and policy analyst with the Health Regulation Division at MDH. Next slide, please. When the original law was passed for assisted living licensure, it was known that it would not be perfect on its first attempt, and that there would be certain aspects and areas that would need further refinement and improvement over time as things became known and as processes were developed for the work. With rulemaking underway and started, and feedback from stakeholders of the Rulemaking Advisory Council, private consumers, providers alike, the notice of a gap of transition between the current structure for a registration and a license to the new single license concept was a large gap. There was nothing in the statute that guided how the department would be able to or be authorized to transition from the current 2-part system to the single part system. That situation led to our language of consensus language of a technical amendment to the assisted living law in December 2020 during the 7th special session. This law addressed several key topics, a few consumer right protections that had been missed earlier on as technical oversights, as well as some which are the increased protection for residents. But the big issue that contained within the 7th special session technical amendment was the ability for the department to be able to transfer housing with service registrants and home care providers into the new system. With the passage of that law, the department then continued its rulemaking, and as Ms. Krieger will continue and provide an update on momentarily, the department also at the time notified committee staff, stakeholders from providers, residents, councils, consumer advocates, consumer advocacy groups, that there are still some other topics that were just not able to be dealt with during the quick time that we had between December and now, and that would take a longer process of engagement. So the department will be facilitating an engagement process with the original stakeholders and those that are interested to find areas of agreement and discuss areas of disagreement on previously mentioned topics, and also novel concepts that have come up from both sides or all sides in the issue and the discovery of information as we move along the process for eventual implementation for assisted living licensure. The department will be facilitating that, and we have been in the communication with all those parties, and we look forward to the opportunity to kind of refine this even more and hopefully come back to this committee with those areas of agreement and that information and update for you to hear and learn about as well. Next slide, please.
Thank you, Mark.
Please
So an
proceed,
update.
Director Kruger.
Thank you. So an update on rulemaking process so far in progress, so far at the department. So we did post the proposed rules and the statement of need and reasonableness on October 8th. And this was posted on our website. And then a notice of hearing was published on December 14th. posting our proposed rules on the Office of Administrative Hearings site, and opening the 30-day public comment period. The hearing was held virtually last week on Tuesday and Wednesday with Administrative Law Judge Ann O'Reilly presiding. So as far as following the hearing and the process of what happens now after having our hearing last week, there is a public comment period that continues after the hearing as well. Judge O'Reilly has extended the public comment period from 5 days to 20 calendar days, and that will close at 4:30 on February 9th. Now, after February 9th, there is a 5-day rebuttal period that goes through until February 17th for the department and members of the public to make rebuttal comments on the comments and not introduce any new evidence during this rebuttal period. Now, after the rebuttal period closes, Judge O'Reilly will prepare her report. And Judge O'Reilly explained last week during the hearing that she intends to issue her report approximately 30 days after February 17th. And Judge O'Reilly's report will be published on the Office of Administrative Hearings and the Department of Health's website once she has completed it. As a summary, we had a total of 25 public comments heard last week, 13 on Tuesday and 12 on Wednesday, and currently approximately 65 comments on the Office of Administrative Hearings website at this time on our proposed rules. Next slide, please. So key areas of comments that we are hearing so far is in 3 distinct areas, one being staffing, the second, emergency preparedness, and third, on contract terminations. All right, and to give an update on the infrastructure development and communication updates, as Diane mentioned, we are implementing assisted living licensure during the time of COVID. We are currently working on hiring and have hired quite a number of staff already, including 10 surveyors, 1 supervisor, 2 enforcement staff, and 2 office staff. We are engaged with development of the IT systems, procedures, and protocols necessary to support the implementation of assisted living licensure and the ongoing operations. And work is underway to develop tools and processes needed for the application system, surveys, investigations, and enforcement. We also understand that communication is going to be key as we move forward. There will need to be communication in various forms for providers, clients, and families, loved ones, or representatives, and for the general public. We will also need to make sure and leverage our partnerships with local public health and counties, in addition to our sister agencies and other stakeholders. We have engaged with sister agencies to assure alignment of policies impacted by this new licensure and successful transition into this new licensure. We have worked with the Department of Human Services, the Ombudsman's Office, both for long-term care and mental health and developmental disabilities, the Board of Examiners for Long-Term Services and Supports, Senior Linkage Line, and the Hub, formerly known as the Disability Hub, have all participated in these discussions and will continue to do so in the months leading up to August 1st. We also have built out a web page on assisted living licensure on the Department of Health's website, where information is available on the proposed rules and rulemaking process. The web page also provides links to sign up for email updates and fact sheets that we are continuing to develop and to publish regarding certain topic areas of assisted living licensure. We have issued a survey to the current housing with services establishments and home care licensees to inquire about their intent to convert to an assisted living facility. And these responses will help the department in its implementation process. And then we also have internal work groups for survey processes and forms internally for the department when we go out for our surveys on assisted living licensure, enforcement, communications and actions, and physical plant requirements. We did put out a draft application to many different stakeholder groups for their review and comments. At this time, we are currently working with Minute on the development of the application and posting around the beginning of May, but we are looking to coordinate with the Board of Long-Term Care Supports and Services to ensure their rollout and our rollout is good and timing works. Providers and potential providers need to be able to see the application prior to August 1st, have time to fill it out, and make sure that the application is in for our staff at the department to review prior to August 1st. And then finally, the Resident Quality of Care and Outcomes Improvement Task Force is underway. The purpose of this task force is to support providers in long-term services by recommending safety and quality practices and infrastructures that drive improvements in assisted living settings. The task force is defined in statute and will play a critical role in strengthening consumer protections that are already in place. The task force is committed to be meeting on an ongoing basis at this time. They have indicated that they'd like to meet monthly leading up to assisted living licensure to bring forth and examine proven best practices and infrastructures that can be applied in these settings. Next slide, please. And then finally, I will wrap up with a timeline slide. And I know that there is a lot on the screen, but just looking at how the department is piecing out all these different areas that go into assisted living licensure and ensuring that we have it on a timeline that brings forth a successful implementation of assisted living licensure on August 1st. And now I will pause and stand for any questions at this time. Thank you.
Well, thank you, Director Kruger and Assistant Commissioner. I just want to thank the Minnesota Department of Health, the Commissioner of Health, and her team for bringing together all the stakeholders and advocates to implement the licensure and the rulemaking. They're doing an amazing job. So I see that we have several questions. I also want to remind the public that they can find the slides on our committee website. So I'm going to start with Representative Bolden. Go ahead, please.
Thank you, Madam Chair, and thank you for this presentation. That was really helpful with good information. I have a question that was comes from a conversation with a constituent who was wondering about residential care homes, and I didn't see those listed specifically, but I'm wondering if they fall into one of the categories that you listed in the beginning and on slide 4. Their concern was that I guess typically those are very pretty small and concerned that some of the kind of requirements may be too difficult for them to keep up with and thus then would go out of business. Can you speak to that a little bit?
Sure. Assistant Commissioner or Director Kruger?
Sure. Madam Chair, this is Lindsay. I can go ahead and help answer that question. Representative Bolden, this is a comment and a concern that we've been hearing on the rulemaking process too. And so at the department, we are thinking about, and as I mentioned, the communication is going to be key. And so we're thinking about how this is going to affect the big providers and the smaller providers too. Now, one of the areas that we're hearing in the rulemaking comments is regarding emergency preparedness. And if the emergency preparedness that is implemented for a large facility can also be implemented for a smaller facility. And so we are working at the department to put out information on how that successfully can be done. And I do feel that with assisted living licensure, it's not going to be a one-size-fits-all approach. The smaller providers are important for this aging population as well. And so we will look to continue to communicate out in ways that we can make this possible for the smaller providers too.
Representative Bolden, you have a follow-up to that?
Nope, thank you very much.
Yeah, I just want to say that, if it's just housing with no services, if it's independent senior living, they're not going to be in that bucket of licensure. Okay, Representative Albright.
Thank you, Madam Chair. Ms. Kruger, I appreciate your mentioning of best practices standards, and I'm just wondering, in other agencies over the past several years, we've heard stories of examinations and site visits that really put the carrot before or put the stick before the carrot in terms of, assisting organizations to be motivated to raise their game to, say, a best practices standards. I'm wondering what you would speak to in terms of the relationship with this new uh, section of code in terms of how will MDH motivate uh, providers from a best practices standards as opposed to one that is more regulation heavy and quite honestly maybe corrosive to the relationship between the state and these care providers.
Director Kruger?
Madam Chair, Representative Albrecht, you bring up a really good point, and I think one of the areas that we're looking at is specifically with the task force and also with the Home Care Advisory Council is taking what we've learned from the past, looking at where we have cited providers in the past and providing education and information about that for best practices in the future so that facilities may see areas that can be improved upon and implemented in a way that the facility then can perform at a higher level. Also, for the advisory council and for the task force, I will be looking for their expertise on those members to bring. Some of the members are providers. Some of the members are from other areas of quality improvement. And so what are their ideas to look at some of those best practices, facilities and facilities that are doing well and how we can implement that for the state of Minnesota and for providers to learn and expand and grow in the upcoming years.
Thank you, Ms. Kruger. Could I ask you to stop sharing your screen? It's easier for me to manage the committee. Thank you.
I'm sure. I just have
Go ahead,
one
Representative.
follow-on.
I just want to make one comment to that. I just want to remind members that Minnesota was the only state that didn't licensure assisted living facilities, and we had significant maltreatment cases that we needed to address. And not all our providers, but some of our providers. And so, there was a real motivation on both sides to regulate and license facilities to protect our most vulnerable older adults. So please proceed, Representative Albright.
Thank you, Madam Chair. And I would agree that the efforts made by the legislature last biennium to move this type of legislation forward was really groundbreaking, and I applaud the efforts of everyone that was involved. Ms. Kruger, as a follow-on to my first question, much like an ombudsman, have we encouraged kind of a peer-to-peer review of the providers themselves to help with those best practices standards to really elevate the game of this industry in the state of Minnesota? How are we partnering with them to really innovate within their own ranks as opposed to driving the ship from an agency level? How are we partnering with them to really come alongside them when and try to innovate? And I bring that up as maybe a shout out to an earlier comment I made to Chair Schultz about a book that she and I are very passionate about, every one of the members on this committee, in reading. And at some point, hopefully you'll get a copy of that. But it's a book that really talks about patient-centered care. Many of you heard about it. It's called Being Mortal by Dr. Atul Gawande. But I really think this is front and center to the beginnings of really putting Minnesota on the map for providing patient-centered care in any setting and allow the providers to cater to the decision-making process that each resident has, as opposed to what the state feels is best for everyone. And I'm wondering if you would be willing to respond to that. Thank you, Madam Chair. I'm completed.
Thank you, Representative Albright. That's a big question. Director Kruger, maybe in very briefly.
Madam Chair, Representative Albrecht, I think you bring up a really good point. In regards to your comment or question on peer-to-peer sharing between facilities, I can't speak to that, but what I can speak to is that we work very closely with the long-term care imperative, with both leading age and care providers, and also the Minnesota Home Care Association on what we are finding and what we are seeing, so that they can work with their members within their organization for best practices and to raise the bar with safety and quality of care. Now, also on the other side, we do work closely with consumer advocate groups too, to be inclusive on both sides of the conversation, so they know and they understand what's happening in facilities, and so that they can report to us areas of concern that we can look further into in these facilities.
Thank you, Director Kruger. I have Representative Newer and then Representative Liebling, and then we're going to proceed to the next presentation. So go ahead, Representative Newer.
Thank you, Madam Chair. I do have two questions. The first one is, Director Kruger, you mentioned IT that Minute is already working on. What does that entail? Does it include mean choices? I'll also ask my second question. Do we have a demographic breakdown based on, also geographical breakdown of individuals who are on these programs? And finally, stakeholders involvement. I know there are several individuals who are involved, but how have we reached out to BIPOC community, meaning Black, Indigenous, minority communities, to be engaged in this conversation? Thank you, Madam Chair.
Great questions. Director Kruger?
Sure. Madam Chair, Representative Noor, you do ask very good questions. Now, regarding with our work with the Minute system, we're working with them on the application right now. So the application for assisted living licensure is going to be built in our current system that's used for renewals. So providers for housing with services and home care providers, they're used to this system on renewals. And so we are building the application for conversion into this system. We are also building the application that's going to be an externally facing application that's going to be a fillable PDF. So instead of having a paper application that is mailed into our office, we are going to work to have that in electronic format on our website. And then it will be uploaded into a portal to the Department of Health, and instead of being mailed into the office. So those are a couple of the projects that we are working on with Minute. Regarding a breakdown of individuals in specific settings or programs, one of the areas is that for housing with services application or renewal or home care providers, it's not a requirement for them to tell us how many clients that they have. So we have mapped out where are the providers in the state and what is their license type of provider, and potentially are they customized living, or do they have payment from the Department of Human Services? And so we are working internally and with sister agency at the Department of Human Services to determine and to be able to understand what is the population, where is it, and how can we get communication out to help support these providers and the clients at this time. And then finally, regarding stakeholders, I think you bring up a very good point, and this is something that I've been working on too over the last several months of this project, is really how do we partner with the Centers of Health Equity at the Department of Health to make sure we know and understand that there are providers that have English as a second language. And so how can we get communication out? As I go back to communication is key, how can we get communication out for those providers to understand, to ensure that there is a successful transition and they have their questions answered for assisted living licensure? Thank you.
Representative Newer, follow up?
Thank you, Madam Chair. Just a quick follow-up. Will you be using some of the assessments to collect data from mean choices?
Director Kruger?
So regarding data collection from Min Choices, Madam Chair, Representative Noor, so one of the things that we have in proposed rules is the uniform consumer guide. I'm sorry if that's not the correct term for it. I don't have it right in front of me. But so as we look forward into, yes, what are the facilities indicating that they are providing services for? How can we begin to build that into a data system as we move forward? That is something that we are thinking about and looking into.
Thank you, Madam Chair. Appreciate it.
Thank you, Representative Noor. And I think it really is important to bring in the BIPOC community as we're developing these rules. So I hope MDH is reaching out to those communities so they can also provide feedback on the rules and share their experience and stories before the administrative law judge issues her final report. Representative Liebling.
Yeah, thank you, Madam Chair. And first of all, I just want to add my thanks to the department. This has just been amazing work done very quickly under very difficult circumstances. So good to see this going forward, and thank you for the report. When we think about consumer protections and the need to have more structure around and do the licensing, one of the things I just like to, I know you might not have this information at hand, but to my knowledge, the payments for these kinds of settings come from a variety of sources, but a lot of it is private pay, right? This is people who have saved up their money, they're paying for it out of their own pocket. I wonder if there's any data about average cost of the service, because when we think about this and the need for consumer protections, we're also thinking about the fact that people are spending their life savings on this kind of housing and service, and what the meaning of that, because this is a lot of money, right? Is that what we're talking about here? We're talking about something that people might save up their whole life to be able to do, and drain their resources pretty quickly.
Director Kruger.
Madam Chair, Representative Liebling, I think as far as average payment or cost, it all depends on the individual and their services and what their service needs are. But this is something that in the future maybe we could look into as far as how much does the cost of services entail, or what do they pay? However, this is not something currently at this time that is gathered by the department.
Added to our to-do list, Chair Liebling.
Always adding. Thank you.
Okay, I think we're gonna move on. I don't see any more hands and we're running out of time. So I wanna introduce our next presenter, Valerie Cook. She's currently the Division Director of the Nursing Facility Rates and Policy at DHS. So welcome, Director Cook. Please share your slides and proceed. Welcome to the committee. You may be on mute because we don't hear you, Director Cook.
Is that better?
We can hear you now. Please
Okay.
proceed.
Good morning, Madam Chair and members of the committee. I think that Dan Pollock wanted to just open with some opening comments first. Could I defer to him, please?
Yes, please. Assistant Commissioner Pollock, please
Okay.
introduce the topic.
Thanks,
Thank
Chair
you.
Schultz. Thanks, everybody. I'm really pleased to be here, and we're glad to have an opportunity to talk about nursing facility rates. Division Director Val Cook is absolutely one of the smartest folks we've got in the entire agency on this topic, so I will defer entirely to her presentation. I wanted to be here for Q&A if needed. And thank you for looking at this issue. She's going to cover a lot of terrain. It's a complex issue in terms of reimbursement. It's been made more complex by the virtue of the pandemic, or the lack of, I shouldn't say virtue, but the advent of the pandemic. And so we want to work with you to understand how this is impacting our long-term care facilities, our nursing homes, and what that means for the future. So with that, I'll turn it over to Val. Thank you.
Thank you, Assistant Commissioner Pollock. And I appreciate everything Director Cook has brought her skills and talent to Minnesota. And we're really grateful that you're able to continue your work in this area. So please proceed.
Thank you. For the record, I'll introduce myself as Valerie Cook, the Division Director for Nursing Facility Rates and Policy with the Department of Human Services. Next slide, please. So I also will begin with providing some general background and the basics of purchasing nursing facility services, followed by more details about our current reimbursement structure, and we'll end with a discussion of financial and payment response to the COVID pandemic. Both the Department of Human Services and the Department of Health have responsibilities for nursing facilities. So our division at DHS is responsible for developing and interpreting policies related to nursing facility reimbursement. We also maintain a system of quality measurement with results published on the Minnesota Nursing Home Report Card. Quality performance is also measured for purposes of quality incentive payment programs. And lastly, we are responsible for auditing annual cost reports and establishing the daily payment rates. MDH is responsible for licensing and inspecting the nursing facilities and doing investigations of allegations of neglect and maltreatment of residents who live in nursing facilities. Next slide, please. So services in nursing facilities are bundled into a comprehensive package of room, board, nursing services, and other support services such as social services or activities. Those are bundled into a daily per diem rate that's established by the department. In Minnesota, which is one of two states in the country that are what we call rate equalization states, meaning that the private pay rates are equalized into set to the Medicaid rate with some exceptions for private rooms. And the package does not include costs for prescription medications, for example, hospitalizations and physician services, and various types of therapy, physical, OT, and speech therapy. Next slide, please. So anyone seeking to get admitted to a Medicaid certified nursing facility is assessed by an assessor to determine that they meet nursing facility level of care. Most admissions to nursing facilities occur following a hospitalization. In 2019, there were approximately 65,000 admissions to Minnesota nursing facilities. And of those, usually over 60% of them stay less than 30 days. So this is in contrast to what was presented in the earlier presentation. So on any one day, there's approximately 22 to 23 residents in nursing facilities. Next slide, please. Approximately $2.5 billion is spent annually on nursing home care in Minnesota. About half of that revenue is paid for by Medicaid. Another quarter is being purchased by private paying residents, and another 30% or so is covered by Medicare and other sources, such as veterans benefits or duly eligible residents enrolled in managed care. Next slide, please. Medicaid average payment rates are increasing over time as would be expected. And as noted here, you could see in the last 2 years, there was about a $10,000 increase in total costs per year. Next slide. Just to share some forecast information, annual Medicaid payments to nursing facilities are projected to grow by 74% over the next 10 years. So that's from about an $808 million base in fiscal year 2016 to about $1.4 billion in 2025. Medicaid, as you know, is a shared cost with state and federal participation. And generally, federal participation covers the Medicaid for nursing facilities at a rate of approximately 50%. The forecast does include a slight decrease in the numbers of residents that will be served over time. I think that we're seeing evidence of that as I share some data on nursing facility closures, and active beds are also declining. Next slide, please. So moving on to our overview of our current reimbursement rate structure, which is commonly known as value-based reimbursement, or VBR. If we could go to the next slide. VBR was established by the legislature in 2015. It was a very large investment of over $400 million in the first 4 years. The notion behind that was to rebase to actual costs, as it was Medicaid rates were primarily known as not covering actual costs, and so this was quite a sea change to move to a cost-based facility system again. Minnesota Medicaid cost-based reimbursement is unique to nursing facilities, not as compared to other programs that DHS implements. And The other feature, other feature about VBR is that it uses a quality score to set care-related spending limits. So let's go to the next slide. The primary goals of passing VBR was to address workforce shortages, primarily low wages, poor benefit packages, recruitment and retention. And it was designed in a way to increase investment in targeted to direct care and care-related services. And the idea that we establish a quality incentive under VBR, meaning that the intention of this was that the state would be willing to pay more for higher quality. Next slide, please. The VBR rate is broken down into 5 components. Care-related costs, such as nursing care and medical supplies, are reimbursed based on costs, subject to the quality-based limit that I just mentioned. Other operating costs, such as dietary, housekeeping, and administration, are reimbursed at the same amount for all nursing facilities in the state. So this component is what we consider a price-based component, and it's established at 105% of the metro median reported costs in those cost categories. So we have basically eliminated the geographic and facility type variation for those specific types of costs. The other thing to note is qualified health insurance costs are treated as a pass-through cost in the external fixed cost component. And I also want to mention that the property rates were not addressed in VBR reform. So overall, Minnesota's rate equalization law means that value-based reimbursement increased costs for private pay residents, as well as quite an increase in Medicaid payment rates. The other feature to note about the VBR structure is there is about a 15 to 27-month lag between the time the facility incurs a cost and when it becomes reflected in their payment rate, typically about 2 years later. Next slide, please. Another unique feature of Minnesota Medicaid rates is that each facility has their own unique set of rates based, as I explained on the previous, based on their costs and price and a number of other features. But beyond that, then each resident's rate also will vary within that facility depending on the resources that are needed to meet their needs, their care needs for each resident. So the resident care needs are determined by a federally mandated clinical assessment, which then ultimately drives what that individual resident's payment rate will be. So for an example, I just wanted to provide an operating rate may vary between as low as $165 a day to a high of $523. So there's quite a variation based on level of needs. So next slide, please. So the purpose of this slide is just to demonstrate the proportion of the rate components for a typical rate. As you can see, the operating component is by far the most significant portion of the total rate. And then breaking out here, a smaller amount is associated with the property rate, which is kind of, associated with what you would call paying rent in some respects. And then the external fixed rates, where those are all the costs that are considered pass-through costs. Next slide, please. So to discuss briefly about how the VBR quality incentive works, it starts with—
Director Cook, could I interrupt? I just have
Yes.
a question on the previous slide. How
Sure.
often are the case mix adjustments, how often are those evaluated for each facility to come up with the case mix?
Madam Chair, the residents are assessed on a quarterly basis, which are called OBRA assessments, and that's what we use to establish the Medicaid and private pay payment rates. So at a minimum, their case mix could change, their case mix rate could change on a quarterly basis, but we do also acknowledge if there's a significant change in their condition.
And I see that Representative Liebling may have a question related to this. Go ahead, Representative Liebling.
Actually, Madam Chair, I could wait.
Okay.
I'll wait till the end.
Okay. Please proceed, Director Cook.
Okay, so next slide. So the quality incentive limit starts with a 7-county metro median care-related cost. So and then the limit from that line moves up or below the line depending on the facility's quality score. we develop a comprehensive quality score based on a mixture of quality measures that looks at short stay and long stay outcomes. And the thing about the quality incentive that we've known, I think all stakers have known, that the level in the original formula was just basically set too low, and continue nursing facilities, very few, less than a handful, are ever limited by this care related limit. So this is an area where we do need to do some, continue to do some work. Next slide. Why don't we move on to the next slide? I'm going to just touch on some general trends that we've seen since the implementation of VBR. Hourly wages of direct care workers have continued to trend upwards. We have seen a very high growth rate in spending on workers' health insurance benefits, which, as a reminder, those are pass-through costs for the facility. We also know, and this pattern hasn't really changed over since pre-VBR days, but care-related spending differs greatly by ownership type and location. So hospital attached facilities have the highest spending, followed by government-owned and nonprofit facilities. For-profit facilities are generally reporting lower costs. And as I mentioned, this is a pattern that kind of continues from the pre-VBR timeframes. The other thing we've noted is metro area facilities continue to have higher costs than facilities in rural areas. We're also seeing an uptick in facilities changing ownership, and I'll be talking a little bit more about that, leading towards some concerns about quality trends that we're noticing. Next slide. This is just a visual of average wage increases for care-related staff. You could see in 2015 through 2017, the early years of VBR, wages of benefits, wages were, climbing here more steeply. And now in the more recent years, you can see, with the exception of LPNs, you can see a leveling off of which would be more in alignment of typical cost of living increases. But I know that this was just, the wages, the direct care wages was just really an important feature of VBR. So I wanted to just share a little more specifics about that. Continuing on to the next slide, to talk about changes of ownership. And this is some history from 2014 on what we're seeing. And I think the point that to make here is that, prior to a change of ownership, 23 nonprofits switched to 11 nonprofits. So we're seeing a shift away from government-owned facilities, and we're seeing a shift away from nonprofit facilities. Next slide. Another trend of interest to share is nursing facility closures. As you can see, primarily those closures are occurring in rural outstate areas with only 4 closures in the metro. The rate of closures is staying pretty steady from year to year, typically 3 to 4 a year, with the exception of 2015. So next slide, please. I'm going to talk about the evaluations that have occurred of VBR to date. So if you move to the next slide. As part of VBR implementation, there was also a legislative report requirement put into law. The first legislative report was published in February 2019, and we do publish this report every 2 years. So we're working on getting the report that'll be published in hopefully early February for your review. The independent evaluation is done by Purdue University in partnership and University of Minnesota. They examine trends and major indicators and outcomes. And I think the thing I really want to emphasize is that for this evaluation period, we really decided to really dig into an analysis of our quality measures and our scoring methods and just the framework before we advance to, once we get that fixed and feel confident about it and have stakeholder collaboration on it, then we start moving to the next stage of trying to redesign the quality incentive. The other thing I want to point out about the legislative report that'll be published next month is that it's covering the cost report periods through 2019. And so that is prior to any of the COVID outbreak. And so the report will not include impact from COVID. Next slide, please. Just to touch on a few recommendations that the evaluation has come out with. Analysis of spending over the VBR implementation period indicates those lower rate facilities prior to VBR continue to be the lower rate facilities after VBR. So there are concerns that lower rate facilities that may have had lower quality are not investing resources to increase their rates and work to improve quality due to that lag that we talked about between incurring the costs and having those costs recognized in their rates. The analysis of quality metrics prior to nursing facility change of ownerships and periods following the CHOW shows a pattern of smaller year-over-year increases in costs and declining quality performance as compared to their peers. This could be a pattern of lower quality facilities are more likely to be sold in the first place, but it also could be a reflection of the disruption of management and declining oversight and disruption of management and oversight through a new owner's transition period. The evaluators have made a number of recommendations for improving our quality measurement system that we agree with and look forward to implementing those changes. And there is a recognition that spending and quality strategies vary across settings. For example, those facilities who primarily serve short stay residents versus a facility primarily serving long stay residents. So it is recommended that in working to redesign the quality incentive that those differences should be kept in mind. So next slide, please. So our next steps and some of the challenges that we're facing is that we will begin stakeholder engagement and share recommended changes to our quality measures and move to adopt the changes where there is a collaborative support. We'll continue to work with stakeholders to develop a more effective VBR quality incentive. Work has been done in collaboration with MDH to update and strengthen licensing standards for operating a nursing facility in Minnesota. So this work is, I think, is important that we pick that work up again and try to keep the momentum going on that. And the other thing, challenge that we have to work through is that CMS has moved to a new case mix classification system for Medicare skilled nursing facility stays. CMS continues to temporarily support the assessment items that we need to operate the Minnesota case mix payment system. However, eventually that support will end and Minnesota will need to transition to a new system. So we really need to be working on planning for that transition. Next slide, please. Finally, I'll just close up a presentation to talk about our COVID response. Minnesota was fortunate enough that we already had an emergency statute in place called noted as Section 12A.10. And this was an opportunity to provide expedited reimbursement to nursing facilities for higher incremental costs of COVID-19. So an additional, we also got a temporary waiver of physician's orders for Medicaid payment for a private room. Under ordinary circumstances, Medicaid will be willing to pay for a medically necessary private room. But with the COVID outbreak, MDH guidance required all admissions to a nursing facility be quarantined for 14 days. This waiver allowed Medicaid to pay for the private room for those 14 days of quarantine, even when a resident was admitted to a nursing facility with no COVID symptoms. We've also obtained a waiver to extend the cost reporting deadline for 60 days from February 1st to April 1st, 2021. This is to allow more time for nursing facilities to reconcile and report how they're going to be using their federal CARES Act funds. CMS also authorized states to use civil monetary penalty funds, or CMP funds, probably more commonly known, for grants up to $3,000 for each facility to purchase devices to help residents communicate electronically with family and friends. And a second round of grants was also authorized for visitation aids, such as outdoor tents, plexiglass barriers, etc. Lastly, Minnesota has a program that limits how much nursing pool agencies can charge nursing facilities for staffing support. We obtained a waiver allowing for an exception to those maximum charges, and is determined on a case-by-case basis. Next slide, please. 12A10 authorized reimbursement to date. We've approved and paid out $3.8 million as of just last December of 2020, and that reflects payments to 20 different facilities. We have an additional 6 million applications that we are currently reviewing that are pending, and this is a reflection of 85 applications, but it's not necessarily 85 different providers, and not necessarily different providers than the first 20 that received payments. Providers are able to submit multiple applications over time. The challenge with 12A10 is the interaction with other COVID relief funds has really created some complications that we are working our way through. Next slide, please. This is just a recap of federal funding sources. When we first moved ahead with using the Emergency Reimbursement Authority under 12A10, where we were not aware of the existence that federal funds would be distributed, particularly in this very large way. We initially anticipated that we would be spending more on 12A10 out of the General Medicaid Fund, but the federal distributions have kind of changed the landscape on that. And so these are various federal funding sources in response to COVID. So we have got the first two phases of Federal CARES Act have been distributed in provider relief funds that were distributed directly to nursing facilities, which was well over $100 million. Phase 3 of the general distribution is underway right now, I believe. There's the Paycheck Protection Program that I think folks are familiar with. FEMA has provided some assistance to our facilities in Minnesota. There's another distribution from the CARES Act that was a targeted distribution for testing funds. And then there was some spending for CARES Act funds that were transferred to local government units, and including the state of Minnesota. And so where we've accessed that is, paying for National Guard support and emergency staffing assistance. The other thing about this is that we are incurring a higher federal share of states' Medicaid costs during this COVID emergency. So our state share has actually been reduced from around 50% to about 41% contribution. Next slide, please. So the Department of Health and Human Services puts out guidance on allowable uses of those care funds. And so they will have the responsibility for oversight to see that they're properly used. They have put out guidance that relief fund payments that are not fully expended on COVID-related expenses may be applied to patient care lost revenues. So this is those interactions again between COVID relief funds, 12A.10 reimbursement, and future rates may need to be sorted out on a case-by-case basis. Next slide, I think we're ready for questions.
Thank you, Director Cook. Wow, that's a lot of information. So let's get to our questions. Chair Liebling, go ahead.
Yeah, thank you, Madam Chair. Yeah, that's a ton of information, and we could talk about this for a long, long time, and I'm sure we will, but thank you for that presentation. I first of all, just wanted to go back to one thing that was said early on about rate equalization. And I just want to really clarify this. We used to get a lot of lobbying from the nursing home industry on rate equalization because rate equalization meant that they could not charge more to a private pay patient than than was being paid by Medicaid. So it meant that Medicaid was your cap for what you could charge. But Ms. Cook, I think what you just said, I think it wasn't clear. You were saying that it seemed like you were saying that the reason that the private pay rate was so high was also because of rate equalization. I think it's because Medicaid does not allow us to charge less for private pay. In other words, Medicaid has to be the lowest rate paid, right? So it's not really rate equalization that creates that problem. It's inherent in the Medicaid system. And I want you to correct me if I'm wrong, because I think it's really an important point. As we raise rates for nursing homes, we are necessarily raising what private pay has to pay as well. Is that correct?
Director Cook?
Madam Chair, Representative Liebling, you are absolutely correct. And so I probably didn't mean to imply that rate equalization created higher rates for private pay, but you are correct. Medicaid has to be the lowest rate paid. And so as Medicaid rates go up, so do private pay rates. That is correct.
Okay, and thank you, Madam Chair. I won't
Representative
take a lot of,
Liebling?
I know time's short. I won't ask all the questions that I have here, but it would be really great to get some information maybe offline about how the wage increases compare with the same kinds of occupations in other settings. I'm really glad to see that those wages have gone up. That was a big reason that we did this thing in the first place, one of the big pushes behind it. So, but I'd like to kind of get some points of comparison offline. And then also it'd be interesting to understand bed availability. We've got some closures you pointed out, but we're always trying to actually reduce our nursing home population, move people to home care. So I'm just kind of interested right now of what the match is between demand for actual nursing home beds and availability. But again, I'll take that totally offline. Thank you very much.
Thank you, Representative Liebling. Other members have questions? If not, I have a few. So Director Cook, I have a question. So this relief money for COVID, if they don't spend their money on healthcare, they can use it to compensate themselves for potential lost revenue. And I'm just wondering, are we going to audit that, or how are we going to know it? Like, are they going to be passing on some of those healthcare expenses to the state and then use the federal dollars to compensate themselves for lost revenue? How will that work?
Madam Chair, at this time, we are requiring before we pay out any additional 12A10 funds that they've reconciled their Federal CARES Act, and they have to submit documentation to us on what they are claiming as uses of their Federal CARES Act funding. At this time, we are not claiming lost revenue. We're not allowing lost revenue to be claimed as CARES Act funding and then come to 12.810 for reimbursement of their expenses. This is really a kind of a messy interaction, and we are seeking CMS clarification on this topic, but we are taking a conservative approach because, I mean, I think the sense is the federal government only wants to pay these costs once. And so we have to untangle this so that we can look at the interaction between lost revenue and actual expenditures. And granted, the CARES Act funding is to help support facilities that will have fixed costs. There will be fewer residents because of the lower occupancy paying for electricity and some of those fixed costs. And so we feel we can work out an equitable way to recognize that, but we do still need to work through some of those complexities.
Thank you, Director Cook. My other point is that we saw lots of change of ownership after we implemented VVR. And I'm just wondering, are we tracking any correlations between change of ownership or ownership type and complaints or low quality scores? So I would like follow up with that if you don't currently know. And then I see that Assistant Commissioner Pollack maybe wants to make a comment. Go ahead.
Madam Chair, just before we get to the chow, I just on your question about the CARES Act money, I just wanted to call attention that slide 25 that listed, 5 or 6 different COVID-related nursing facility funding changes. There was a lot of information presented, so you might not have caught it. Each of those individually required about a 10-step process where we went to commissioner authority, MMB authority, governor's office, legislative chairs had an opportunity for a veto. These were done painstakingly, carefully, and really with both taxpayer interest in mind and the COVID response in mind. So I just want to make sure that the committee understands that, when we say we're not allowing them to use dollars for a certain purpose, that was after a painstaking process that really considered the fact that a lot of different Medicaid providers are experiencing economic disarray and pain from the pandemic. We tried to target COVID relief dollars as closely as possible to the needs of the providers.
Thank you for that clarification, Assistant Commissioner Pollack. We appreciate that. Any other questions from members? No. Yes. Representative Noor, go ahead, please.
Thank you, Madam Chair, and thank you, Assistant Commissioner. I just wanted to inquire, I don't know if I missed it, are there any waivers that we're requesting from the CMS that is in the works and related to this program?
Commissioner Pollack?
Thank you, Representative Noor and Chair Schultz. I think that slide 25 does delineate the waivers that we've received for nursing facility reimbursement on COVID, and what Director Cook was alluding to on the interaction where we're going to ask for additional clarification. It goes to the question of whether economic relief for empty beds is something that they intended to be paid before COVID expenses or vice versa. It's a complication of our cost-based system. And Director Cook, please weigh in if I missed anything.
Madam Chair and Representative Noor, I could just quickly add that we didn't need to get CMS waivers for some of these payment issues, but the Department of Health, of course, issued a tremendous number of regulatory waivers for nursing facilities. So I just wanted to clarify, you know, we're primarily focused on the financial perspective, but your question may have been about regulatory waivers as well.
Thank you, Director Cook. Representative Noor?
Oh, thank you so much. That's what I wanted to inquire. Thank you.
Okay. Representative Bonner?
Sorry, I want to make sure I'm unmuted. So I had two quick questions, and I'll throw them out there, and I'm not sure who is the most appropriate person to address them. But the first one was, in an earlier presentation, we talked a little bit about this common practice of having building versus services being provided by different individuals. And I guess because I know there's a lot of new members to the committee and some of us who are new to this in general, if you could maybe speak to the reason behind that and that practice and what the implications are on the overall system and the regulations that we've put into place. And then the second question was, there was an allusion to the fact that we've seen a reduction in the number of facilities across the state, and in particular that there was in 2015 a more significant reduction in the number of those facilities. So one, I'm curious if somebody could give us a little bit of background around what might have been the trigger for some of that reduction in 2015, and maybe a little bit of a commentary on why we think we're seeing a larger reduction in greater Minnesota in even just the most recent year.
Thank you, Representative Bonner. Some of those questions may have to be answered offline. We're running out of time, but if someone wants to jump in for 1 minute at response, either Commissioner Pollack or Director Cook.
I'll start on the first question, the housing and services. This will only take 20 seconds. And the issue has to do with that over the years, Minnesota was trying to provide home and community-based services access and developed a methodology by which we paid for housing, and you could get support for housing, and then we paid for services. And the primary goal of the Medicaid program was to provide services that were person-centered and in community. And housing in those HCBS settings was not part of the Medicaid rate, as opposed to in nursing homes where housing is part of the rate.
Okay, thank you. And I think we'll answer the rest of your questions, Representative Bonner, offline, if that's okay. I want to remind members that tomorrow we are going to have a presentation on Families First. So you'll learn all about that federal program and how Minnesota is responding to the federal direction in Families First program. That is Wednesday. That's all I have for today, and we stand adjourned. Thank you, members.